I am this much. So good evening and a very warm welcome to all distinguished experts to this advisory board meet, Projestine Club, the expert forum. Mankind Pharma had become the first Indian company to launch dydrogesterone in December 2019. It was the result of tireless commitment and dedication of our scientists who worked relentlessly for almost a decade at Mankind Research Center to realize this feat. The present advisory board is intended to discuss the critical role of progesterone in supporting luteal phase following IVF and also threatened abortion and recurrent miscarriage. But before we begin the actual agenda for this evening, let me share with you a brief journey of Mankind Pharma in Indian pharma industry. We began a journey in 1995, founded by the first generation of entrepreneurs, our Honorable Chairman, Mr. R.C. Juneja ji, with a vision of becoming the most admired pharma company in India. And keeping that vision in mind, today we are amongst the top 5 fastest growing pharma companies with #1 rank in terms of prescriptions and 4th in terms of top line revenue, which is nearing approximately $1 billion. Over the years, we have well represented ourselves in almost all major therapeutic segments with leadership positions in many. We are amongst the top 5 pharma companies in India in anti-infectives, gynecology and women healthcare, gastroenterology, cardiology, and endocrinology. Of late, we have been working very sincerely on the innovations in formulations and dosage forms for drug delivery as well. One of the main factors behind our success of being the fastest growing company is also an operational excellence and strong supply chain, which enables us to reach the highest coverage of 600,000 pharmacies and 400,000 healthcare professionals with a large field force of approximately 14,000. Mankind's Research Center, MRC, is located in Manesar, Delhi, NCR. This state-of-the-art research facility has a dedicated team of over 400 scientists who are involved in complex and innovative research. Some of our clinical research and biopharmaceutical capabilities include new drug discovery and research, advanced pharmacokinetic modeling and biostatistics, formulations and development, and clinical research. Mankind's new drug discovery research pipeline includes targets for diabetes mellitus, arthritis, and NASH. And I'm very happy to share with you all that a novel GPR119 agonist for type 2 diabetes mellitus has successfully entered the phase 1 clinical trials after animal studies have shown better glycemic control over sitagliptin. We're also working on the front of COVID care, where we are collaborating with Daewoo Pharmaceuticals from Korea to repurpose injectable niclosamide against COVID. Being a leading pharma company, Mankind Pharma has always aspired to be recognized as a top brand both in revenue and in serving people through its CSR activities. After the onset of the second wave, Mankind has pledged a 100 crore contribution for our frontline warriors, including doctors, paramedical staff, chemists, police personnel, and their families. We have distributed more than 5,000 oxygen cylinders and oxygen concentrators with an approximate worth of more than 40 crores. And we have also started a 70-bedded COVID hospital in Gurugram to serve the patients suffering from the disease. Dear doctors, it is with your patronage that Mankind has reached so far. Our endeavor to partner with healthcare providers like you will help us to achieve the objective and mission of improved healthcare in India and abroad. With this, I would request my colleague, Dr. Ashutosh, to take the privilege of introducing our chairperson and moderator for this evening. Over to you, Ashutosh.
Thank you, Dr. Rajat. Let me have the honor and privilege to introduce our chairperson for the evening, none other than Dr. P. Balamba. She is a consultant at Shani Hospital in Barkatpur, Hyderabad. Professor Emeritus Obs and Gynae, NTR Health University. She is the president of Urogynecology, Pelvic Floor Dysfunction and Incontinence Association, Hyderabad. Also president of Family Planning Association of India, Hyderabad chapter. Organizing chairperson of AICOG 2011, member of Committee on Surrogacy in State of Telangana, member of Medical Advisory Committee to Chief Minister of Andhra Pradesh. She has been conferred British International Doctors Association Award in 2005. With this, I hand over the session to Dr. Balamba ma'am to introduce our two moderators and speakers and welcome other thought leaders present on the forum. Over to you, ma'am.
Thank you, Dr. Ashutosh. It's my proud privilege to introduce Dr. Ramani Devi, who is going to speak to us today. She's the Managing Director of Ramakrishna Medical Center and Janani Fertility Center, Tiruchirappalli, National Vice President, FOXI 2020, peer review member of Journal of Obstetrics and Gynecology of India, and ARCOG, International Editorial Board member of Bangladesh Journal of Fertility and Sterility, editorial board member of the International Journal of Human Reproduction, and executive committee member of SOVSI Tamil Nadu chapter. I have great pleasure in introducing Dr. Ramani. She's a very good speaker, and she's been very good in her delivering her lectures also. Next, I would like to introduce Dr. Manish Pandya, Professor and HOD of Obstetrics and Gynecology, Scientific Research Committee, Gujarat. Special awards and achievements are Dynamic Indian of Millennium by KG Foundation, Gynec Excellence Award by FOXI 2020. He has published 8 books by JP Publications, 3 chapters in postgraduate series by PI Publication, 1 chapter on DUB by Elsevier Publication, 40 papers in the journal, Indian Journal of Obstetrics and Gynecology Research, and 5 papers in IJBCP, 1 paper in OAGG, 1 paper in IJMS-PH, 2 papers in IJRCOG International, 536 presentations as faculty in conference. I have great pleasure in introducing Dr. Manish Pandya. They are going to take us through about dydrogesterone and infertility and abortion, threatened abortions and recurrent pregnancy loss, as well as preterm labor. And I welcome all the advisory board members from all over. And it's a pleasure to meet all of you, at least virtually, after 2 years. So I welcome you all for this meeting. May I present Dr. Ramani first? Who is going to speak first, Dr. Manish or?
Dr. Manish, ma'am. Dr. Manish Pandya, ma'am.
So I have the pleasure in inviting Dr. Manish to present his talk.
Thank you, madam. Good evening, all. Thank you for kind words. Ashutosh, can I share my screen?
Yes, sir. Please go ahead.
Okay. Is my screen visible?
Yeah.
Yes, sir.
So, good evening, all. Welcome to this Projestine Club. Thanks for kind words, madam. Recently, I had published more than 54 papers, and I will ask all researchers to become a member of ORCID. ORCID will register your all work, and 79 research work field data are registered in ORCID, and it's a very good platform. So all researchers, I would request that they could put their work on ORCID. Welcome to Mankind webinar. How beautifully everything is arranged by Almighty, that as soon as child enters the world, it finds mother ready to take care of it. She is there, mother is something new, said by Rajneesh, the blessings of mother of mine and so many mothers to whom we had delivered. 3 books written by me is recommended in RCOG as a reading material. Atlas of Petalicocardiography and Technique of IVF Made Easy has gone for 2nd edition. And I am an editor-in-chief of 2 journals, Indian Journal of Obstetrics and Gynecology and Open Access Journal in India. So for last 50 minutes, we will discuss something regarding luteal phase in frozen cycle. This is today's need of talk. And what is normal in IVF and XC? What is the importance of progesterone in FET cycle? Progesterone in FET, what are the evidence and what is guideline support? That is, we are talking about the latest guideline in 2022 by SOA. Why dydrogesterone a preferred option and what are the evidence is supporting in favor of dydrogesterone? If you want to go for FET cycle, we must think that that should be very good soil. So we are discussing different method for endometrial preparation in FET. What is the role of progesterone in endometrial preparation? We can compare the protocols in patient undergoing FET and how we can go for down-regulated cycle that is very latest in the field of FET, that is DROI, a novel endometrial preparation approach for frozen embryo transfer. Since the beginning of IVF, we all know that we must give luteal phase support. Then question arises, why? Why want to give very good support in luteal phase? Just 1 second, I would to shut down my cameras because I am looking myself. Just 1 second, just 1 second. Okay. Yes, I'm making it down. Is my screen still visible? Na?
Yes, yes, yes.
Okay, okay. Sorry for this little bit inconvenience because I am watching myself in front. So why I want to discuss luteal phase support in IVF? Because since years we know that when we are doing in vitro fertilization, we are giving very good ovulation induction, or we are doing COH, just controlled ovulation induction by gonadotropin. For that, we are catastrophizing the pituitary by giving either GnRH agonist or GnRH antagonist. They will require all the FSH and LH molecule, and then we are giving exogenous FSH and LH from outside. So natural support is already little bit lost. Second, while doing the ovum pickup, we are not picking the ovum, we are also picking the granulosa cell. And granulosa cell are the mother of corpus luteum, and corpus luteum is mother of very good progesterone. So there is a deficient corpus luteum, that's why there is deficient luteal phase support in IVF. So because of this, there is areoluteolysis in absence of exogenous hormone support, premature decline in estrogen and progesterone, and this will significantly reduce the success rate in IVF treatment. And this will give nephrotic effect on endometrial receptivity and endometrial implantation. So we know that we are very good nurtured by our mother. Our mother has generated enough amount of endogenous progesterone to nurture us. And since the beginning of OC pills, Pincus has designed ethinyl estradiol and progesterone. Till date, the ethinyl estradiol remains same, 0.03. All the changes are there in progesterone because maximum effect we require from progesterone and maximum side effect we are facing from progesterone. So different variety of progesterone are generated worldwide. And if you see, the progesterone is very essential for establishment in early pregnancy. Progesterone is also maintained for maintenance of the pregnancy, and it will significantly improve the outcome of pregnancy, number one, and it is critical to support luteal phase support in IVF. This we are watching the fresh cycle. You can see in fresh cycle, we are stimulating patient. We are giving all the hormones. So we have get a very good estrogen and progesterone. At the time of pickup, we are picking the ovum. So there are little bit of corpus luteum and there is luteoplacental shift, and the requirement of progesterone is not that much in natural cycle because we have got support of endogenous progesterone in the body. But when we are talking about FET cycle, in FET cycle, we are not giving hormone from outside. There is no estrogen and progesterone. Sometimes we are doing GnRH analogs. So we have to give hormone supplement in all these patients, and the requirement of progesterone is much more compared to natural cycle. If these things are understood in our mind, then we think that how much progesterone we should give in FET cycle. So there is a very good need of progesterone supplementation in FET cycle because there is lack of corpus luteum, there is less circulating progesterone hormone concentration, and for endometrial preparation before embryo transfer, we are dependent on endogenous or exogenous progesterone. But what at the end of embryo transfer, we will require very good pregnancy conducive endometrium. What we mean by pregnancy conducive endometrium, the triple line endometrium should convert into ground glass. If we see electron microscopically, if we do the cut section or histopathology of this endometrium, you will see very good pinopodal activity. So these pinopores are good anchor because they have got alpha V beta 3 intergrins. And then at that time, there is a very good osteoporosis. So if soil is good and we implant very good blastocysts into this endometrium at maximum implantation potential point, believe me, we are going to get very good result. And nowadays, people are doing FET cycle and people are getting very good results because we understand the embryology, the histology, the endocrinology of endometrium utmost. And when we are doing the FET cycle, we have to become very good at our ultrasound, number one. And number two, we have to justify the endometrial milieu of that endometrium. So at proper time, we can transfer this embryo in utero to get the maximum results. Why progesterone are preferred supplementation in FET? Because we all know that we are using HCG, there are high chances of ovarian hyperstimulation syndrome. Sometimes with GnRH, we have got premature endogenous surge. The only option left in our hand is progesterone supplementation. It is very good to get very good success cycle in frozen embryo transfer. There is very good paper by Sapraev and et al. that best live birth rate in participant with luteal phase support with progesterone during natural cycle compared to natural cycle without progesterone or with estrogen and progesterone supplementation cycle. They had done 463 patients, and what they concluded that progesterone double odd ratio with live birth after spontaneous ovulation. So in all natural cycle, if we support this all patient with progesterone, then there is a very good control or very good odd ratio, and we can get very good live baby rate. So live birth rate significantly higher in women who is receiving progesterone starting on day of embryo transfer compared to those who did not receive the progesterone. You can see less than 10%, more than 10% rise. If you use progesterone, then 10% pregnancy is more. And for IVF, 10% is much more. And this is a randomized control trial done around 435 patients. This is very good paper says that low progesterone level on the day before natural cycle FET is negatively associated with live birth. So if we have got progesterone less than 10 nanogram per ml, you can see pregnancy rate is 33. But if this progesterone level goes up to more than 10 nanogram per ml, then pregnancy rises up to 48.6%, low miscarriage rate, and very good live birth rate. There is a logistic regression curve which says if you compare the live birth, if you see the progesterone concentration, higher the progesterone concentration, live birth rate is very high. And they done this study on pre-implantation genetic diagnosed embryo. If they had done PGD, and in no PGD ratio, the pregnancy rate is less. But if there is PGD is done, and if you implant that embryo, normal embryo, the pregnancy rate of live birth rate is very high in this all patient with FET. This is a very good latest guideline by ASHRAE in 2022. What it says that use progesterone is recommended in luteal phase support after IVF and ICSI. Initiation of progesterone for luteal phase support should be between evening on the day of oocyte retrieval and day 3 post oocyte retrieval. So we should give very good time for endometrium to get progestinized. Progesterone for luteal phase support should be administered at least until the day of pregnancy test. So it should be at least 15 days, either 1 TDS or 1 QDS, depends upon you are doing fresh cycle or FET cycle. And dydrogesterone is probably recommended for LPS. And this is not me saying, this is ASHRAE Reproductive Endocrinology Guideline. And this is published on March 31, 2022. When ASHRAE is supporting dydrogesterone, means dydrogesterone is very good for infertility, very good for IVF, and very good for luteal phase support. Professor Raj Raghupati has done beautiful study in 2000 when they had talked about allogenic immune response to paternal antigen. And they had found that dydrogesterone, erythroprogesterone, has got very good immunomodulatory effect. If you use dydrogesterone, there is more PIVF, that is pregnancy-induced blocking factor. And because of that, there is a very good Th2 cytokine production. Now in this COVID era, we all know antigen and antibody reaction. Whenever any antigen enter in our body, there is formation of antibody by T and B lymphocytes. And these T and B lymphocytes are making two kind of pathways, that is Th1 and Th2. When this Th1 pathway is activated, it is inflammatory. So it is abortive. When there is Th1 is activated, there is formation of symmetrical antibody. The interleukins are destructive and there is formation of natural killer cell. But when there is Th2 cytokines or Th2 response is activated by antigen antibody reaction, there is formation of asymmetrical antibody, there is formation of protective cytokines, and there is decrease in the natural killer cell, and there is increase in the PIVF. And they had proved in this endocrinology conference, and they had done scientific study, and Professor Raj Raghupati has stated that why there is abortion, because so many times sperm considered as an antigen. We all know that we are formed from one X chromosome from our mother and one Y chromosome from our father, or two X chromosome from our mother if we are lady. There is a joke that why lady is grounded, because if you see there are two X, both are grounded just like table. And if you see in male, there is X and Y. Y has got only one limb, so it moves like pendulum. joke apart. But when this mother considered this sperm as an antigen, against that antigen, she develops antibody. And because of that, there is Th1 cytokines are activated and there is abortion of the fetus. But we have to thank our mother that our mother has generated enough amount of Th2 cytokines or Th2 pathway, immunomodulatory pathway, and they had protected our pregnancy in utero, and we are in this outside. So advantage of oral dydrogesterone over oral progesterone, we all know that there is a better bioavailability by oral progesterone, that is dydrogesterone. It is more selective binding, almost exclusively at the progesterone receptor. 10 to 20 times lower dose compare of micronized progesterone. Dydrogesterone is that much, only 10 milligram, 30 milligram, 40 milligram we can do. Dydrogesterone retains its immunomodulatory activity even after it is converted into major metabolite. I am happy to share this is Professor Raj Raghupati, and we had got very good conversation while we are meeting at the conference in Pune. And this is Professor Howard Carr at the leisure activity. So what is the advantage of dydrogesterone and its safety? Advantage of dydrogesterone, it is a mild mineralocorticoid property. There is no androgenic adverse effect like hirsutism, voice senses, acne. No musculizing changes in the fetus, because first baby born with the use of dydrogesterone, it was in 1960, 9 years before I had born. And since then, there are more than 20 million babies delivered worldwide, and till date, there is no musculizing effect, no congenital heart disease, no side effect is there of dydrogesterone. If you see, there is a high safety profile due to unique receptor features of dydrogesterone. High safety and tolerability profile both in mother and child, and there is no changes in sexual development of fetus due to its androgenic and anti-androgenic effect. So this molecule are used worldwide since last 60 years, more than 20 million babies delivered worldwide, and since 1960, there is no congenital malformation after the use of dydrogesterone. I am happy to share this, my paper, which is published in 2016, that progesterone supplementation during luteal phase in treatment of infertility in first trimester. And this paper was published in Open Access Journal in 2016. What is our aim? To review the literature. And in this paper, we had did study from 1980 to 2015, because this paper was published in 2016. We had done all the studies, those who had used progesterone, and we had concluded that dydrogesterone oral exhibits an overall higher pregnancy rate compared to micronized progesterone, 30 versus 11.5, and with very less side effect. So it concluded that relative effectiveness, safety, optimal route, and duration of oral vaginal intramuscular progesterone formulation in topic of ongoing debate. Future investigation with longer follow-up and large couple sample size compared with different route of administration doses and timing of administrations are warranted. If you want to use progesterone in intrauterine insemination, if you compare dydrogesterone, it shows greater 85% satisfaction level compared to intravaginal micronized progesterone. Dydrogesterone exhibit a higher pregnancy rate compared to micronized progesterone, 30 versus 11%. In IVF, oral micronized progesterone is not as effective as intravaginal or IM progesterone as a luteal phase support in IVF cycle. Oral dydrogesterone showed a similar pregnancy and miscarriage rate when compared to intravaginal micronized progesterone at a luteal phase support in cycle. Intravaginal progesterone can be considered as a valuable alternative to IM progesterone injection for luteal phase support, and there is no adverse effect or congenital abnormality were observed in newborn mother who received progesterone in clinical studies. And I'm happy to share that after publishing this paper, there are 500 copies asked by USA library, and this is a very good GIF made by Mankind company. You can see there is a very good GIF. So you know that for security, they delivered the bypass, there is low affinity, dydrogesterone is 6 times more happier. And I am happy to share that if you see at the downstairs bottom, Dydroderm or Dydrobone has used my paper as a material in this. So I am very much thankful to Mankind company. So giving me that much popularity of using my paper in this GIF. Here downstairs, you can see Pandya MR, and this is all of 2016 paper. And I'm also happy that I'm the member of Dydrobone 1 million. So congratulations, Mankind Company, for becoming now 1 million, and now you're doing very good job in the academics and diabetics also. So this is the GIF of Dydrobone, and that we are discussing. It is very good in pregnancy loss, threatened phase, and luteal phase insufficiency. This is a very good paper by Ozer, that oral dydrogesterone compared with micronized vaginal progesterone in luteal phase support in modified natural cycle of it, that we will discuss afterwards. Higher ongoing pregnancy rate if you use dydrogesterone. There is similar biochemical and clinical pregnancy rate if you compare micronized vaginal gel and dydrogesterone. You can see ongoing pregnancy rate is very high in dydrogesterone group. Clinical pregnancy rate is also very high, 77%. And if you see the overall satisfaction ratio is 4.0. So dydrogesterone is effective, easy to use option with fewer intolerability side effect, and can be used as a luteal phase support in modified natural cycle FET. If we see this odd ratio, we have to pay our tribute to Professor Chakravarti, who has recently passed in his very good study in 2005 of using dydrogesterone compared with progesterone event. If you see this odd ratio, we all know that this favors dydrogesterone. Only one study says that micro favors progesterone, otherwise all study is favoring dydrogesterone. So dydrogesterone was significant effectively as vaginal progesterone for luteal phase support. There is lower dissatisfaction with oral dydrogesterone reported, and oral dydrogesterone is associated with improved pregnancy and clinical rate. If we compare oral dydrogesterone versus micronized vaginal progesterone in luteal phase effect, and there is a very good systemic review and meta-analysis, and they are checking on live birth, clinical pregnancy rate, and miscarriage rate. You can see that if you use oral dydrogesterone, there is a very good high pregnancy rate, 25%, clinical pregnancy rate is 31%, and miscarriage rate is only 16%. The participant study is more than 3,000, 4,000, and 1,000. So what is our interpretation? Dydrogesterone is better or no clinical relevant difference, and there is significant effect in favor of synthetic progesterone versus natural progesterone. And one sentence I would like to add here, that if we are considering micronized progesterone as a natural, then we have to consider dydrogesterone also natural, because both are made from same plant origin, that is Discoria villosa. If we go for micronization, small particles, it become micronized progesterone, and some procota or procata, we will break the bond and making is a retroprogesterone, then it is a dydrogesterone. So if dydrogesterone is synthetic, then micronized is also synthetic, and if micronized is natural, then dydrogesterone is also natural. So oral dydrogesterone is as effective as vaginal progesterone for luteal phase support in embryo transfer after IVF and ICSI. So in summary of my first talk, that progesterone supplementation in luteal phase support is essential in women going IVF and ICSI. There is absence of exogenous hormone support negatively impact endometrial receptivity and embryo implantation. There is a very good evidence from several trials to demonstrate the efficacy of dydrogesterone in IVF. Oral dydrogesterone has significantly advantage over progesterone in terms of bioavailability and receptor affinity. Better patient satisfaction is observed with dydrogesterone than micronized vaginal progesterone, and dydrogesterone has a high safety and tolerability profile in both mother and child. Now, I would like to invite all my expert patients, because we are going for this panel discussion, that why is oral dydrogesterone preferred over conventional oral progesterone? Is oral dydrogesterone is as effective as vaginal micronized progesterone? Number one. And what is appropriate for timing of progesterone supplementation, and what is ideal for progesterone support? Okay. Can I see my all participants here?
Can I ask you a question, Dr. Manish?
Yes, yes, madam. Yes, madam. This forum is for this asking.
We do get lots of this IVF conceptions coming to us.
Yes, madam.
Whether it
Yes,
is
madam.
a FET or a natural cycle or even fresh cycle IVF.
Yes, madam.
It is not only oral dydrogesterone. They give them the vaginal progesterone gel. They give dydrogesterone. They give intramuscular micronized progesterone. So many progesterones are added the patient is loaded with progesterone. When
Yes,
we are
Balamma,
talking
madam.
about when we are
Yes,
talking
yes, madam.
about dydrogesterone, why do we give so many progesterones to a single patient?
Madam, this is a common question in every IVF talk. If you see any prescription of any IVF specialist, they are using dydrogesterone 1 TDS. They are making 400 milligram of vaginal progesterone and they are giving intramuscular progesterone.
Yes.
So one sentence I am talking about this situation that I am traveling in a bus. I have got 2 pass and 1 ticket. Then Balamma madam asked me a question. If I lost the ticket, then I have got again pass. If I lost the 2 passes, then I have got ticket.
That is a
So
pathetic joke, I know.
Yeah, madam. But why, madam, this is happening? I am doing IVF since last 21 years. And I born with dydrogesterone. My first presentation was dydrogesterone in 2000.
Yeah,
So I'm
even
20.
before, see, you said it was, you were born in 69, I think. Because
Yeah, yes, madam. Yes, madam.
69. So
Yeah.
we have been using dydrogesterone since 69, since you were born.
Yes,
I
madam.
have got 50 years of experience. And
Yes,
that was
madam.
the only progesterone available apart from the 17 alpha hydroxyprogesterone acid that I
Yes, madam.
you know.
That,
So we
that
did
is.
use that, but those days we didn't know how dydrogesterone acted and all those research was not done, but still we
Yes,
used
madam.
and we got very good results. Okay. So now, of course, we know how dydrogesterone acts, and the recent addition of even nitric oxide production also is there. And
Yeah.
I always wonder whether we should use it even to prevent preeclampsia also, you know.
Yes, madam. Yes, madam. I had
Yeah.
done study. I had used dydrogesterone up to 32 weeks.
Okay.
Because once we are using dydrogesterone act on when arginic acid is converted into citrulline.
Yes.
There is a production of nitric oxide.
That's
And
what
there
I
is
mean.
very good paper that if you use dydrogesterone in increasing dose, we are finding very good progesterone receptor on placenta also.
Yes.
And they had done study by collecting the
syncytial
placenta.
trophoblast has the progesterone
Yeah.
receptors. I know that.
And they had done study and they had taken the blood from a fetus when they used dydrogesterone and the control in which they had not used dydrogesterone. They think that because the dydrogesterone acting as a nitric oxide precursor, there is a little bit increment in the Likert of the TIH patient, and we can continue this patient up to 30 to 34 weeks, and we can give 20 milligram dydrogesterone up to 34 weeks. And believe me, if there is 2 to 3 centimeter of increase in the Likert or 100 gram of increase in the birth weight, the baby will be very fine in IUGRs. So there is a very good role of dydrogesterone in IUGR babies and in PIH. As regarding your first question, if you use dydrogesterone judiciously 1 TDS in fresh cycle and 40 milligram in FET cycle, there is no need of use of any vaginal tablet or intramuscular injection. But you have to believe.
I concur with you, but why make the patient spend so much money?
That's why, madam. That's why I am telling that you have to believe in the drug which you are using, and use this drug judiciously, and believe in that this drug will give you enough amount of progesterone to nurture the pregnancy. What happens so many times, if there is bombardment of progesterone, there is a miscarriage.
Correct. That's what
because
I mean.
ati sarvatra vyarjyate. That is therefore there is no need of too much of dydrogesterone.
Dr. Ramani, is she on? Dr. Ramani?
Anybody wants to ask something, or we will go for the second topic of endometrial perforation?
Yes, madam, I am on. See,
yes, ma'am.
I also want you to comment on this bombardment of progesterones in IVF cycles, you know, all types of progesterones.
I think all the IVF consultants, including me, we are very fond of using dydrogesterone as the first line. Plus, combined with one more of micronized vaginal progesterone. I'm sure Dr. Manish will also use either a vaginal gel or a vaginal form of capsule. Again, we don't want to use even a single pregnancy. We don't want to miss. And the most important thing is dydrogesterone acts by the immunomodulatory effect. And again, one more thing I wanted to discuss with Dr. Manish is what will be the level of cutoff of progesterone before you go for the FET cycles?
Madam, it should be more than 10 nanogram. So if it is more than...
But I personally feel, sir, it should be individualized according to the
yes, madam.
center, because we have done in our center a trial how much the relationship of outcome of IVF conception to that of the transfer day of progesterone. So we find in our center, whenever the level is beyond 20, we had the maximum pregnancy. 15 to 20 was okay, but less than 10, definitely we did not even get a single pregnancy. I think that has to be again individualized. And again, the start of the progesterone should be preferably on the day of oocyte pickup. And it should not be delayed to the maximum of day 3. And one more thing, Madam, Balama Madam, my mother is also a very senior consultant. Now she is almost nearing 90. She used to tell me that her favorite drug was dydrogesterone. And for patients who are coming simply with history of short-term infertility, what they used to do in those days, where they never had any facilities of follicular monitoring, nothing, they used to do a simple dilatation and curettage, followed by luteal support of dydrogesterone. Probably retrospectively, when we think, dilatation and curettage has promoted the formation of endometrial growth factors. That has like even we can see
that was a scratching. That was an endometrial scratching.
A full cycle, we have come back to scratching the endometrium now.
Yes.
Because some of the patients come and say, why are you not doing a DNC for me with infertility when they come? My mother is asking, or my grandmother is asking, why are you not doing a DNC? So these are all the things, you know, we are going full circle to the behind, you know, and then getting back to all those things.
So there are some literature evidence saying that scratching doesn't help, but definitely there is increase in the growth factor production after doing a gentle scratching.
Yeah, in all preterm labors, recurrent abortions, all those conditions, we use the dydrogesterone.
Yes.
We have all used it.
1 minute. It is not only scratching the endometrium. Yes, agreed that it gives a stimulation to the endometrium, etc. in the previous cycle, but it is also getting a uniform endometrium.
Yes, that is what I wanted to add up, Rekha. Sometimes when we don't get when we prepare a patient for an FET cycle, the pattern may not be trilaminar. It may be at one area, it will be thick, one area, it will be thin. But if you do a scratching, automatically this will promote a beautiful trilaminar thing.
Yes, madam.
Yes.
And another answer to Dr. Balamba madam's question that why do we bombard the patients with progesterone is that as we know that bioavailability of that drug is good, this drug is not good. Patient don't use the vaginal progesterone, don't come for the IM injection, etc. As Ramani madam, we are very scared that we don't want to lose any single cycle because we are answerable at least for the money what they are paid. And ultimately none of us are doing, at least many of us are not doing the blood progesterone value on the day of FET. So somehow we want that value to be achieved around 15 because as Ramani madam said, success rate is much less below 10. Of course, it doesn't happen. It's between 15 to 20, at least in my practice, you have to maintain. So when we don't check, we want to be doubly sure that patient is given enough support of progesterone. And so we give the multiple progesterones.
And another thing is when you are using a dydrogesterone, there is no need to check the P4 level.
Yes, madam.
Because that is not reflected in the blood.
Yes.
So there is no need. That is one advantage.
Yes.
Thank you very much, Dr. Ramani and Dr. Pandya and Dr. Rekha. Now I think we'll go on to the next talk.
Next talk, madam. Okay. So now my next talk is endometrial preparation in FET. Okay, how we prepare the endometrium. Then most important question is why there are different endometrial preparation protocol in FET. Because everybody think that we should do in true natural cycle with luteal phase support or without luteal phase support. We can use this drug in modified luteal phase support with modified natural cycle. We can use hormones with GnRH and without GnRH. And there is mild ovulation stimulation of clomiphene citrate with aromatase inhibitor. So factors of choice of this protocol, madam has rightly said, it should be on patient preference, clinical feasibility, and cost effectiveness. So what we mean by true natural cycle? We all know that we should synchronize of embryo and endometrial development to maximize the pregnancy rate, achieved by endometrial preparation by using patient's own follicular sex steroid hormones, and that is the basics of natural cycle FET. Timing of embryo transfer is determined by investing the spontaneous LH search. We can do progesterone, and ovulation is estimated 36 to 40 hours by blood LH level. And success of natural cycle depends on accurately determining the ovulation time. We should transfer our embryo in the precise implantation window and precise estimation of endometrial receptivity. And this will come by experience. You can see the progesterone, you can see the sonography, and there is a very good thing of sonoendocrinology. So we should believe that sonography is utmost important, and we can do with very good ultrasound, and we can manage our patients for successful natural cycle IVF pregnancy. So what are the challenges? Determine the time of spontaneous LH search, variability amongst the cycle and patients. 1 or 2 measurement must be performed daily by accurately determining of the LH search, and ovulation may occur unexpectedly and can lead to difficulty in adjusting time of thawing and embryo transfer. So these are the challenges we are facing with the true natural cycle. Then we have to convert ourselves into modified cycle. So ovulation is triggered by administration of HCG during natural cycle when mean follicular diameter is 16 to 20 millimeter. There is a development of dominant follicle we have to regularly investigate. And what is the advantage of modified cycle? That doesn't require LH measurement because we are giving HCG. So there is a natural LH search. So HCG administration induces ovulation, increases serum production or progesterone production by luteal, mid-luteal phase support. So true natural cycle or modified natural cycle all need luteal phase support. So we must have an optimum progesterone is crucial for establishing and maintenance of intrauterine pregnancy. As Madam had rightly said, you have to give progesterone from the day of ovum pickup. At that time, you can use dydrogesterone, you can use vaginal progesterone for progestonization of the endometrium. On the day of embryo transfer, you can see very good progestonization of the endometrium, ground glass appearance, you can see the activity, and you have to do very good USSR, ultrasound score for endometrium, and there is a score that we can see that endometrium is moving. There is a very good vascularity. You can see very good path of endometrium. And at this time, if you implant the embryo at the maximum implantation potential point, because every uterus has got different MIP point, depends upon the uterus, we can have to see both the tubes ostia, and they are putting at the 1 point level, and this is known as maximum implantation potential. So we have to synchronicity between the endometrium, and it should not be started not less than LH search plus day 3. So there is very good rationale. If you see lots of evidence are there, and we must time the endometrium for luteal phase support administration in natural cycle, totally natural cycle or modified natural cycle. So luteal phase support in total natural cycle, there is a significant increase in the live birth rate, and luteal breast support in modified natural cycle is comparable with reproductive outcome with or without luteal phase support. So what are the hormonal replacement therapy? We are giving estrogen and progesterone administration consecutively. Time of thawing ET is planned according to the commencement of progesterone support from what day. We have to consider this is a precise ovum pickup day. On that day, we are not picking the ovum in FET cycle, but we are thinking that this day the endometrium is very good triple line. Now we have to make this endometrium progestonize. So we have to do commencement or use of progesterone to make this endometrium very good. And there is an advantage by both physician and patients that we can monitor this cycle, and we can schedule that it should not come on Sunday, so we don't waste our Sunday. So it is all planned thing in IVF, but you have to plan very judiciously. Sometimes disadvantage, sometimes of costing. There is an increasing cost of potential adverse event associated with more estrogen supplementation. So we have to beware ourselves. So how we are giving estrogen? Given at the beginning of cycle, it will suppress the dominant follicle. Introduced before 4th day of cycle, continued until endometrium thickness is 8 mm. So we have to gradually increasing the estrogen given to the patients, and there are different variety of estrogen available in market. So you have to justify that which estrogen is best for this patient, and you have to believe in the company in which you are using the estrogen, either well rate. Higher miscarriage rate with shorter estrogen priming, that is less than 10 days, and maybe prolonged up to 28 days to 36 days in FET cycle. So many times we are not getting very good endometrium. So to increase the dose of estrogen, and we have to bring very good triannular, then we have to give progesterone support. That progesterone support initial depends on the endometrial thickness, only recommended when endometrium is thickness more than 8 millimeter. Third treatment is with GnRH analogs. What it will do, it will suppress the hypothalamo-pituitary axis by GnRH antagonists and performed in HRT cycles. Suppression of protocol is highly efficient to avoid ovulation. It down-regulates the pituitary and prevent follicular development. There is a very big advantage of decreased cancellation cycle because of down-regulation, everything is in your hand. And what is the drawback? Less patient-friendly compared to HRT without suppression, because in suppression, there is a long window of suppression. We all know that we have to consider this HRT cycle. We have to think that this is HCG, this is typical ovum pickup day or ovum retrieval day. And then we have to utilize the things and we have to give progesterone either on day 3 or day 5, we have to do FET. In total natural cycle, we are not doing anything. We are not giving HCG. So just go for LS search, use progesterone support, and you can transfer the embryo when we have got very good progesteronization of the endometrium, 8 millimeter of endometrium. And in modified natural cycle, we all know that we don't have to go for this LS search. We are giving HCG. So on the day of HCG, we are considering this is the ovum pickup date, and then we have to transfer according to the ovum, according to the embryo. Into we are transferring either day 3 or day 5 plus 6. What is mild ovulation stimulation protocol? There is a very good rationale that to improve subtle defect of folliculogenesis in subsequent luteal phase. There is the advantage of mild ovulation stimulation that it avoids reports risk of thromboembolic events associated with lethargy. And we can use clomiphene citrate 50 to 100 milligram per day, or we can use letrozole 2.5 to 5 milligram per day, or sometimes we can use FSH in very low dose of less than 150 per day. Agent starts on day 2 to 5. We can see the follicular response. We can give HCG just like same on 70 day. When follicle is 17 mm, endometrium is very good, or estradiol level is more than 150 picogram per level. Only thing that we are not doing the ovum pickup and we are just transferring the follicle. Even though we have to use progesterone because there is a very good role of progesterone, it is necessary for implantation and pregnancy survival. Exogenous progesterone in endometrial preparation for oocyte donor IVF cycle in highly receptive endometrium. Higher concentration of progesterone may be required in the cases of endometrial related infertility. There is a very good study by Professor Zhang on optimal endometrial preparation protocol. What they use, they had done pregnancy outcome better in patient who is receiving hormone treatment with 3 cycle of GnRH agonist. Patient receiving hormone treatment with GnRH has got higher implantation rate, clinical pregnancy rate, and live birth rate compared to modified natural cycle group. So increased expression of endometrial receptivity and desuggestion marker in patient who underwent hormone cycle with GnRH analogs, and you can see that those patients who had undergone this hormone cycle, all the graphs, if you see this is a modified natural cycle, you can see live birth pregnancy. Ultimately, end of the day, what we want is live birth ratio, and it's very good if you use this endometrial preparation. Okay, start my video. Okay. Yes, sorry, my video was off. So optimal endometrial preparation cycle, natural versus modified natural versus AC. AC means artificial cycle. So exceptionally biochemical pregnancy rate, patient treated by modified natural cycle protocol has got higher pregnancy outcome compared with natural cycle FET. Higher biochemical pregnancy rate was observed in artificial cycle FET. A program cycle may be necessary for women with anovulatory cycles, and normo-ovulating women may be afforded by natural cycle protocol. You can see If you compare all this cycle, the live birth rate is very good in all group of 32, 36, and 26%. So treatment outcome with different protocol, what the protocol you want to use. And there is latest protocol is DROI. This is a down-regulated ovulation induction cycle for FET. We can use luteinizing hormone, that is LA, leuprolide acetate, 3.75. We have to wait up to at least 8 weeks. Start with low dose of gonadotropin. Same use 10,000 or 5,000 hcg. Don't go for pickup and you do FET cycle. So it is just like mimicking your fresh cycle, but here you are not doing the pickup. So this is a very good protocol for FET cycle, and they had proven that DROI, that is down regulate ovulation induction FET versus modified natural cycle FET, there is a significant increase in implantation rate with DROI FET group. You can see very good implantation rate, 54%. Rate of clinical pregnancy and ongoing pregnancy rate is very high with DROI FET. Effect of DROI might be associated with improving endometrial receptivity. Only thing we have got risk of possible OHSS because we are not picking the ovum. If you compare other method, DROI protocol can be considered as a more efficient and promising protocol because everything is in your hand. If you compare ongoing pregnancy rate, it is 69%, fantastically high. Compared to twin pregnancy rate is 21%. And ongoing pregnancy rate in this cycle is very good with DROI. So even though for this endometrial preparation, we have to use dydrogesterone because reproductive outcome in FET cycle, similar both in oral dydrogesterone as micronized progesterone rate. If you see biochemical pregnancy, clinical pregnancy rate, everything is very high compared to micronized progesterone. So oral dydrogesterone are more patient-friendly approach for endometrial preparation in FET cycle, and this is prepared by Professor McCall in 2022. So every worldwide people are in favor of using dydrogesterone in natural as well as FET cycle. So dydrogesterone usage is utmost in endometrial preparation. You can use dydrogesterone supplementation on day 2, day 3, or day 5 of progesterone administration in FET cycle, depending upon the embryo stage. Systematic dydrogesterone supplementation is as effective as individual supplementation according to serum progesterone level following administration of vaginal progesterone. And there is a very good advantage that easier FET schedule and limits patient visits for monitoring and maintains optimal FET cycle. And this paper is published in 2021. So in summary, different endometrial promising protocol can be used for FET. You can use natural cycle, you can use modified natural cycle, has got higher clinical pregnancy rate and live birth rate compared to natural cycle FET. HRT mimics endocrine condition of endometrium of natural cycle in artificial cycle. If you compare clinical pregnancy rate are obtained with hormone replacement therapy with GnRH and without GnRH, we can prime the timing of embryo transfer depends on the protocol used. Progesterone is absolutely necessary to prepare endometrium to be receptive for implantation embryo, pregnancy conducive endometrium, very good pinopodal activity, very good alpha B beta 3 integrins, and very good osteopontin. There is no consensus on the best protocol for endometrial preparation. That's why we have got 5 different protocols, and latest is DROI. The novel down-regulated ovulation induction protocol is very efficient and promising method, just like mimicking the fresh cycle. So at the end, we should be happy. The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. So at the end, we should be happy and we should thank Almighty that they have given us very good protocol in our hand for fresh and frozen cycle. So we have to do justice to our patients. So my next questions are, is luteal phase support is required in endometrial preparation by natural FET cycle? What is in your clinical practice? Which are the endometrial preparation protocol is generally followed and why? And question 3, is there a significant difference in reproductive outcome in patient undergoing HRT with or without GnRH agonist? Now this forum is open for discussion. I would like to share my screen and I'm stopping sharing my screen and I can see all the beautiful faces. Rekha madam, Meena madam, Balama madam, Dr. Swastik, Dr. Chitra.
Yeah, can I ask all the ART specialists to comment on this? Because I'm not an ART specialist. I'm a general obstetrician and a gynecologist. So I would like the fertility specialist to talk about this preparation and the DRO, especially down-regulated ovulation induction cycles.
Yeah, can I talk, ma'am?
Yeah.
Yes, please, sir.
Yeah, this is Dr. Gaurav from Bangalore.
Yes,
regarding the ideal protocol, what I follow is most of the protocol will be HRT protocol, start on plain estradiol valerate. Regarding that one which you talked about, the recent protocol, I'm a little hesitant because you have to take it with a pinch of salt because you are more worried about the OHSS plus you have
Yes,
the cost, plus the study which is showing that it is a small number of patients. So we should not go with that such large numbers. So ideally best is you have to keep the patient safe. That is why you have mostly turned into the frozen cycles. Secondly, for natural cycle FET, ideal places not required for a progesterone supplementation, but we are doing a blastocyst transfer. Generally, we give a single, whatever preferred method. My preferred method is dydrogesterone. But rest of the cycles, because you, as you said in your presentation, actual cycle is very tedious and patient may not come for so much follow-ups and the scans. So the best is you do a HRT cycle, see the ideal endometrial preparation, the thickness goes up to 8 mm and then proceed with your progesterone supplementation.
So, sir, you are using HCG also?
No.
No.
Just
HCG.
plain HRT. Yeah, you give estradiol valerate, start with your estradiol valerate in upgraded dosages, and then according to the thickness, start progesterone and plan for the frozen embryo transfer.
Only dydrogesterone.
Yes, madam.
No, sir. In practice, I give both dydrogesterone and vaginal progesterone.
Yes,
as
fantastic.
we had discussed. So everybody is wary of. Plus, the second thing is, as you, the first part, the vaginal progesterone, you cannot directly correlate with the blood levels. So
yes, sir.
Individualization was the best thing, which madam already told about it. Some centers follow the 10 cutoff, some centers follow the 15. We generally follow the 10, but that is not necessary. So every center has to have their own cutoff according to whatever the results and protocols they're following.
Yes.
Fantastic. Thank you, sir. Thanks you for inputs.
Oh,
Madam,
thank you, sir. It was a wonderful presentation.
Madam, we have
You,
we do this minimal stimulation protocol as well for FET. As he says, major times we do HRT, but we do this minimal stimulation protocol when they don't respond very well to the HRT alone. So that also seems to be a very good thing. And of course, you have to support the luteal phase, but that also works very good.
Thank you, madam. Thank you.
Yeah, but Dr. Chitra and myself, we work in the same unit, that is Janani Fertility Center. And she has rightly said that HRT, if we are not getting the endometrium good, then we definitely minimal stimulation protocol. We just use letrozole plus a minimal dose of HMG so that we get 1 to 2 follicles, then give the HCG and go transfer. In natural cycle, I think it is always very difficult. And if you get a follicle, maybe you need to give HCG, time it, and then go for FET. That will be our mode of thing. And for you have rightly pointed out, for endometriosis patient, because of increased progesterone resistance, the dose of progesterone luteal phase support has to be very high. And in patients with endometriosis or adenomyosis, our treatment modality is we go for oocyte pickup, freeze the embryos, downregulate the patient with 3 or 4 doses of long-acting GnRH analog. Then just at the, when you finish the GnRH on day 28, you start the HRT. So that fantastic is our way of doing. And with that, we are our results have come out much better than the previous one. And again, now the recent trend is that if you want to reduce, because we know that in adenomyosis, there is increased uterine contractility. And again, there will be definitely difficulty in embryo transfer and because of the cavity irregularity. So all those things can be overcome by giving not only this GnRH analog, but also we can combine with letrozole as well as dyneges. The idea of giving letrozole is it can convert, that it can suppress aromatase. that is not only present in the central level, but also in the local
uterine level.
tissue, plus dynegest. The idea of adding dynegest has got a very good anti-inflammatory action. VEGF can be promoted. So the combination of these things can reduce the volume of the uterus. It can reduce the contractility. And then we have to think about the junctional zone thickness. That is very important before endometrial preparation, because any junctional zone that is beyond 9 to 10 millimeter, that is an utter failure. And the best results are when the junctional zone thickness is around 7 to 8 millimeter. So that we need to have a watch when we are doing for FET cycles for adenomyosis patients. Then one more thing I wanted to add is, then this letrozole cycle, I would like to share one interesting patient.
Yes,
I
ma'am.
started the FET cycle with the letrozole. Patient had a bleed on the day before her scheduled HCG estimation. Because she had a bleed, she was very much disgusted and she wanted to go back. Then after a week's time, one of her local consultants called me saying that patient has got an excessive vomit. Then I told her to get a vaginal scan done. It was a nice single gestational sac. So that means even in a letrozole-induced cycle, there is in the absence of luteal phase support, the endogenous corpus luteum is capable of supplementing supporting the pregnancy. So, but whatever it is, you need to give definite high support of luteal phase. Support is indicated, and FET cycles, I think I am convinced with the either a HRT protocol or a minimal stimulation protocol with letrozole and 1 or 2 doses of HMG. So that is our protocol.
This down regulation protocol, I think, the time that it takes is
long.
It
takes a long time.
And the drug that the patient would want, the drug the patient would require will be much higher. Because after down regulation, we have all noticed that when you try to give HMG, the dose that is required is much higher. Again, the cost is going to raise for a FET. So all of us, we practically don't want all these things to occur. We want to keep that at least minimum. Because already she has gone through an IVF. You want to keep at least the preparation cycle a little less costly. So yes, and definitely any cycle where you have even induced ovulation, for that matter, if you have triggered ovulation with HCG or leuprolide, you definitely have to support the luteal phase. Even
sir, I would like to.
Yes, sir. Yes, sir.
Yes, sir.
Yes.
Sir, what is your take on for the endometrial preparation? What is your take on additives such as L-arginine, sildenafil usage along with the estradiol?
It is just the ice on the cake.
Add-ons.
Add-on. It doesn't give that much of help. Basically, as Madam has rightly mentioned, use the drug which will definitely give you the result, that is estradiol valrate. Use dydrogest, because dydrogest and dydrogesterone both are from the same family. They are both same progesterone. Madam, recently we had made the guideline of usage of dydrogesterone in endometriosis. That was 1 week before in Jaipur, in Nandita's tenure as a SR president. We are making this guideline. So you can use dydrogest and dydrogesterone both in the patient, in which those who want to become pregnant and those who are adolescent. So we can use this both molecules same, because both are from the same progesterone family. So if you want to use sildenafil, if you want to use L-arginine, if you want to use vitamin E, if you want to use acupuncture, if you want to use any Ayurvedic preparation, you are free to use, but there is no data suggesting that it will increase the endometrium.
Only thing is vitamin D has got a role in prevention of miscarriage, that is being given in ESHRE guideline. And one more thing is regarding the use of dydrogesterone in endometriosis patient, I was the one who was behind making this GCPR for endometriosis when I was a chairperson. So we had put a clause that dydrogesterone can be given for mild and minimal endometriosis after cauterization, because these patients, they don't have, inhibition of ovulation is not there. But by the immunomodulatory effect of dydrogesterone will have a favorable effect on the TH1 to TH2 shift, as well as the cytokines, as well as the interleukins, which are modified. So I am in the habit of giving dydrogesterone 10 milligram BID from day 5 to day 25. See, like minimal cases, tubal factor is normal, male factor is normal. If the patient doesn't want to come for a frequent visit, I just put them on this drug. And the supportive evidence is by our own past Foxy president, Dr. Trivedi sir. Prakash Trivedi sir has published a paper where he has utilized this and he has found an spontaneous conception rate of 40 to 50%. So
Madam, first stop of dydrogesterone in India was dydrogesterone used in endometriosis.
Yes.
By Prakash Trivedi only.
Yes, sir.
In NMOGS conference. So this was drug which was started using in endometriosis. Then we found that this is very good in infertility. Then Professor Grisinger in 2016 paper came. Now everybody is using this drug in infertility. In 2005, we have got conference in Russia and China, and I was participating in this as a faculty. At that time, China, they are not using dydrogesterone as an infertility molecule in 2005. Now we have got maximum paper of usage of dydrogesterone from China only.
China, yeah.
We proceed further. May I now thank you very much, Dr. Manish Patia.
Madam.
Thank you, madam. Thank you.
Very lucid talk. Now, may I ask Dr. Ramani Devi to proceed with that talk?
Balamba madam, input from my side would be like regarding the down-regulated cycles. Hello?
Yes, madam. You are audible.
Yeah, regarding the down-regulated cycles, I feel when we do the HRT cycles, most of the cycles we do is HRT cycles. The estrogen starting day before, as Dr. Manish has presented, that itself is a down-regulation and prevents the follicles to come. Means follicles emerging. So a role of using down regulation is only in those cases where, in spite of the estrogen administration early, if the follicles have emerged in the probably in the next cycle, that is what we would do.
Yes, that we
Fantastic.
also follow. That is prior to the next cycle. Start with Progenova, and one more thing is that is also able, if you want to have a stimulation cycle that gives uniform cohort of follicles.
Yes,
that is one thing what we have observed in our okay, I think we are having a very good, nice discussion. Now let me start sharing my experience on this recurrent pregnancy loss and preterm labor. Because once when you have done the luteal phase support, when you have delivered, when the conception has occurred, the most important thing is we don't want to lose even a single baby that has conceived through IVF because of pregnancy loss or preterm labor. But all of us know that it's not so, because even in a natural conception, even 100 pregnancies are there, only 30 they land up with the fetus. So the rest of the abortions, they happen even before the patient feels that she has become pregnant or in the very early, late luteal phase. So we need to have something to support the luteal phase, about which Dr. Manish had explained very beautifully. The next question is about threatened abortion and recurrent miscarriage. Both of them are very, very disgusting problems. And when a patient has got a threatened abortion and recurrent miscarriage, then how we are going to handle it? What is the role of progestin? What is the role of dydrogesterone in preventing the pregnancy loss and threatened abortion? And what does the clinical evidence say? And what the guideline supports? So then comes the second part of my talk will be on medical management of preterm labor, because preterm labor is another nuance. And there are so many risk factors for preterm labor which we can pick up, and there are so many things, newer things coming in with the pathogenesis of preterm labor. And we know very well that use of progestin supplementation in preterm birth helps to prevent. And then what is the role in dydrogesterone in preterm labor? So that first coming to the recurrent pregnancy loss and threatened abortion, WHO says that recurrent pregnancy loss is more than 3 pregnancy losses, 20 weeks of pregnancy. But ASRM says it is even 2 pregnancy losses. We have to consider them as a recurrent pregnancy loss. That's 20% increased risk of RPL following 2 abortion, and pregnant as the women plan the pregnancy at a later age, they need earlier investigation, because many a times our women are bothered about the career orientation and they want to plan their pregnancy very late. So even a single abortion, I think in this current situation, we need to investigate. So the impact is, it has got a psychological trauma, especially to the women, and they are devastated, depressed, and they don't want this to be repeated. And too much of anxiety, which is again going to cause infertility. So the incidence of recurrent pregnancy loss is 1 to 5% of the couples are affected by RPL, with significant consequences concerning their partnership and the quality of life. So there are so many societies, the Israel Society, ASRM, and German Society, Austrian Society, Swiss Society, Royal College, they have all come out with the guidelines. That's all between 2011 and 2018. Now, coming to the causes of recurrent pregnancy loss, there can be an explained cause, and most often it is unexplained. Explained causes may be genetic, either a paternal or maternal, or it could be anatomical factors like abnormality of the uterus or with the cervix, or it could be an endocrine cause like luteal phase insufficiency or diabetes or thyroid dysfunction or etc. Or it could be immune factors, thrombophilic factors, and then infective agents, bacterial vaginosis, Apla syndrome, and environment. So the environmental factors, most of them, they come under the unexplained thing, because in places where there is increased pollution, then the chances of abortion and RPL are going to be high. So pregnancy and immunological miracle of immune tolerance. We all know that 50% of it's a fetus is an allograft, and still the mother tolerates the fetus. And how does the mother tolerate the fetus? If we understand that, then we can find out what is the cause for abortion. So mainly the immunological factors in recurrent pregnancy loss plays a major role. It is well known that maternal immune system is not ignorant of the fetus, but it recognizes and responds to the antigens from the developing embryo. Therefore, establishing the appropriate maternal tolerance towards embryo is crucial for securing implantation and a successful pregnancy. See, mothers and fetuses are always genetically different, and how the mother protects or inhibits the rejection is by forming a mechanical barrier or lack of HLA-2 antigen expression on the trophoblast, expression of unique HLA-1 molecules which are in favor of protecting the fetus, suppression of the maternal immune response, and local immune suppression. So the maternal adaptive immunity is mainly by trophoblastic antigens such as T helper cells, T cytotoxic cells, Treg cells or the T regulatory cells, and the B cells which are involved in regulation of the adaptive immunity. All of us know that TH1 is not a good one. There should be a shift from TH1 to TH2. The Treg cell should be more. And again, there is recognition of active signal through T cell receptors stimulate the differentiation of CD3 and CD4 T cells in specific T cell subs such as TH2, TH1, TH2, TH9, TH17, TH22, and follicular TH cell. Each of these subsets, they have a significant distinct role in human pregnancy. So now coming to this, how this helper cell profiles gets altered in recurrent pregnancy loss. This is a bit of a complicated picture, but I can make it simplified. It is in the implantation phase that it gets into the endometrium, then post-implantation. For this, there should be this TH1 should be suppressed. There should be, again, TH17 should be suppressed, because by suppression of this interferon gamma and tumor necrosis alpha, interleukin 2, interleukin 6, 17, 21, and all these pro-inflammatory factors are suppressed. But whereas this Treg cells is capable of suppressing this TH2 and goes in favor of TH2 helper cells as well as TH22. So all these things will protect the trophoblast from the pathogens and inflammation, and they promote the allograft tolerance. Later, after the post-implantation, we need this for the late gestation, TFH, that is follicular, this T follicular cell that is being needed for favoring the humoral immunity. So again, the current thing is in reproduction is the role of microbiome. See, the uterine cavity as well as the vagina should have a normal microbiome where there should be a higher level of this lactobacillus. So whenever there is good bacilli or whenever this lactobacillus, it should be a minimum of 90% of lactobacillus should be present in the uterine cavity. And then what happens is this will suppress the TH2, this will suppress the TH17, favoring TH2 to Treg cells, and then uterine natural killer cell activity is suppressed. This will promote also the extravillous trophoblast to gain the access into the spiral arterioles, so that the spiral arterioles are converted into wide. So by this, the microbiome, natural microbiome helps in the support and the improper implantation. But vice versa happens when there is abnormal microbiome. All these pro-inflammatory factors are promoted. There is increased uterine natural cell activity. This extravillous trophoblast fails to invade the spiral artery. That will result in reduced blood flow or abnormal implantation. Incomplete remodeling of the placenta happens that will lead to abortion. So now let us see what is the role of progesterone. Patients with low progesterone are found to be 23 times more likely to experience a miscarriage than those with a high progesterone. In early pregnancy, progesterone is the one that prepares the endometrium for implantation and maintains the gestational sac. And the role of, again, the progesterone is modulation of the... please, others, can you put yourself in mute? So the role of progesterone is it modulates the maternal immune system. So whatever the immune aberration I have described in my previous slide, that is all modulated by the progesterone. It improves the uteroplacental circulation by converting the spiral arterioles as well as by promoting the nitric oxide, and it can suppress the inflammatory response. It is a wonderful agent to reduce the uterine contractility, thereby making the uterus quiescent and the implantation to be promoted. So again, this is progesterone dependent immunoregulation. That is very, very important because progesterone is capable of producing progesterone induced blocking factor that is very, very specific. And this is found to be lower in the recurrent miscarriage than in the uneventful pregnancies. It has an excellent immunomodulating effect. Key role in stabilizing the TH2 dominance. Cytokine balance is corrected. Significantly lowers the unexplained miscarriage, and usually this PIBF is detected 14 days after the embryo transfer in IVF patient. So all these things are prerequisites for a normal implantation. So the use of different progestins in, time memorial, we have been using progestins in treatment of threatened and idiopathic miscarriages. And the commonly used progestins are either an oral micronized progestin or an oral dydrogesterone or a vaginal progestin. So a oral micronized progestin, the available data suggests there is a role in preterm labor, but not in threatened or recurrent abortion. And we know very well from all these previous slides I have shown that definitely oral dydrogesterone has got a very good role in prevention of recurrent miscarriage by the immunomodulatory effect. And again, it can be used even for threatened abortion as well as recurrent miscarriage as a prophylactic one. And vaginal microprogestin is available evidence is insufficient to recommend its use. And moreover, the use of vaginal microprogesterone in patients with threatened abortion, they are to some extent, they are reluctant to use anything vaginally in the presence of vaginal bleeding. So now coming to progesterone in treating threatened abortion. So when you treat a patient with progesterone compared with a placebo, this was a study by Wahabi et al. Says that the summary of his finding is the miscarriage rate in placebo treatment is 242 per 1,000 compared to 138 per 1,000, and in preterm birth is 91 versus 84, and congenital anomalies are 13. So numerator versus 9 in progesterone treated group. So we can boldly, so there was one sometime back, there was a lot of thing about the congenital anomalies that are associated either with a vaginal micronized progesterone or with dydrogesterone, but I think now we have overcome all of that. It is not higher than that of a controlled population. So coming to the immunomodulatory role, it sustains survival of the embryo by shifting the immune system towards non-inflammatory Th2 cytokine, increases the nitric oxide production, improves the blood flow and oxygen supply, plays a main role in the myometrium, making it quiescent. It does not suppress the pituitary gonadal axis and makes it suitable option in the case of threatened miscarriage. So this particular slide is very, very important because this has been by Said et al. And Ibrahim, where they have shown that the levels of interleukin-4, interferon gamma, Th2 to Th1 to Th2 ratio and serum progestin level in patients with threatened abortion after the use of, before and after the use of dydrogesterone compared with the control group, especially in interleukin-4, the levels after interleukin-4 is a favorable interleukin. So it has got an improvement in the level after treatment with the dydrogesterone, and interferon gamma is reduced, as well as there is a favorable shift of Th1 to Th2, and serum progesterone levels are quite high when patients are treated with dydrogesterone. So it has got a protective effect. Again, this was a study by Park et al., where they have used a oral dydrogesterone versus control treatment in threatened abortion. And if you see in the forest plot, it favors the favor of the results are in favor of oral dydrogesterone when compared to control group. Similarly, when they did a comparative study of oral dydrogesterone with vaginal progestin, see, few of the studies were in favor of oral, that is one study, but ultimately the oral dydrogesterone and vaginal progesterone, in no way oral dydrogesterone is inferior to vaginal progestin in this particular study. So again, we should recollect our Lotus 1 and 2 trial, which was done in India for support of luteal phase support, where they have compared the dydrogesterone with oral micronized vaginal progestin and vaginal progestin, where they have come to a conclusion in dydrogesterone is in no way inferior to the oral or vaginal use of micronized progesterone. So again, this was again a study by our own member, Professor Kanan Elikar and Ashish Kale, where they have comparative studied the dydrogesterone versus micronized vaginal progestin in patients with RPL presenting with early vaginal bleeding. The results of the study was oral dydrogesterone is more effective than MVP, that is vaginal progesterone, in management of patients with vaginal bleeding. And again, the time taken for the bleeding to get arrested is very much shorter with dydrogesterone, and they found out that there is a higher viable pregnancy rate at 24 weeks as well as term with dydrogesterone when compared to MVP. Again, lesser adverse effects are noted with dydrogesterone compared to MVP. So that again, there was another study by Wang et al., where the dydrogesterone in threatened miscarriage due to corpus luteal insufficiency. Enough of references in enough has been discussed by Dr. Manish Pandya, where you need to have the progesterone for corpus luteal insufficiency. Again, the use of the results of dydrogesterone in corpus luteal insufficiency says the levels of HCG, estrogen and progesterone are significantly higher than with progestin alone, and miscarriage is successfully prevented in almost 87% of the cases, and there is significant low birth rate as well as postpartum hemorrhage in dydrogesterone group when compared to micronized progesterone. Again, micronized dydrogesterone in threatened miscarriage, the results of systemic review is miscarriage, that is you come again this study by Karp, none other than Harvard Karp, says that miscarriage dydrogesterone versus control group miscarriage rate is very, very low, 13%, and dydrogesterone is associated with 47% reduction in odds of miscarriage, and again it is associated with the lower trend to miscarriage than that of the standard care. So this was again a Wang study where he has compared dydrogesterone with the natural progesterone in treating threatened abortion, and he found out that it has got a favorable effect towards the dydrogesterone. So dydrogesterone has got a lower risk of miscarriage than the natural progestin, and lower risk of miscarriage when compared to the vaginal administration of progestin, and it is superior to the natural progestin in treatment of threatened miscarriage. So the same, almost the same dydrogesterone in recurrent spontaneous abortion again says the same results. It is much better than the natural progesterone and lowered risk of miscarriage, and it is superior to the natural progesterone in treatment of threatened miscarriage. So this was again a promise trial, very famous trial that was conducted in UK and Netherlands by Professor Kumarasamy et al., where they have used more than 800 patients in many centers, and they have, the objective was to find out what is the live birth clinical rate after 34 weeks of completed weeks of gestation. There they have used utrogestan, and in this promise trial, when you see that micronized vaginal progesterone versus placebo, there was no difference. But only thing they could find out was, as the number of abortions increased, it was favoring progesterone rather than placebo trial. So this was the one that was published in recent AJOG journal in 2020. So again, coming to oral dydrogesterone, our own Indian study by Professor Ashok Kumar, who is the secretary of ICOG. Again, they have done by Sudha Prasad and Ashok Kumar, where they have found out interleukin 4, interleukin 10, tumor necrosis alpha, interferon gamma, TH1 to TH2 shift. All was in favor of dydrogesterone group rather than that of the placebo group. So that proves that dydrogesterone in Indian population, it has got a favorable effect in management of threatened abortion as well as in recurrent pregnancy loss. So this was in Eshrey 2017 study says used in vaginal progesterone used in early pregnancy has got no beneficial effect in women with unexplained RPL. But whereas oral dydrogesterone has got some evidence and to support initiation when fetal heart action can be confirmed. It is found to be effective. So Eshrey guidelines that was updated in 2022, that is a draft guideline which we received. The vaginal progestin may improve the live birth rate in women with 3 or more pregnancy losses and vaginal blood loss in a subsequent pregnancy. There is a strong evidence, but dydrogesterone orally, it is initiated when the fetal heart can be confirmed, may be effective, but trials are needed, and there is definitely some evidence. So the evidence is, but let us come to see what is Foxy position statement that was done in 2015. So that in threatened miscarriage, micronized progesterone 400 milligram vaginally till 12 weeks of pregnancy can be relative risk of miscarriage rate is reduced to 47%, as well as dydrogesterone can be given 10 milligram BD orally till 20 weeks of pregnancy, and decision should be based on clinician's discretion until strong evidence is available to recommend the routine use. To summarize, progesterone is crucial in the maintenance of pregnancy. Pregnancy protective action of oral dydrogesterone is due to shift from TH1 to TH2 dominance. Clinical evidence supports the role of dydrogesterone in threatened abortion and RPL. Oral dydrogesterone is reported to be superior to natural progestin in treatment of threatened miscarriage. Oral progestin is more effective than MVP in patients presenting with vaginal bleeding during early pregnancy. The dose required for oral progestin is only maximum of 40 milligram per day when compared to 400 or 600 milligram of micronized vaginal progesterone in treating threatened miscarriages or recurrent pregnancy loss. And the side effects are found to be, it is orally available. Orally, it can be taken when compared to the vaginal use of micronized progesterone. So with this, let us move on to the panel discussion. Some of the questions which I would like to pose for the panelists. What is the function of maternal immune response in protecting the pregnancy? I think
fantastic presentation, madam.
Participants, please. Yeah. Thank you,
yes,
sir.
Madam. It was a very good presentation.
It's a good presentation. Yeah. It's a good presentation.
So, yes.
Thank you, madam.
Yeah, but this immune modulatory function unit is very, very important, I think, because you were asking about maternal immune response, because we all know fetal is a semi-allograft.
Yes.
After all, so it can be rejected, and this is very, very important for us to do this, give dydrogesterone has been proven to be very good immunomodulatory hormone, isn't it?
Yes, yes, madam.
So that I think is, is going to be very good in usage. And like you said, like your mother was using, we were also using it since times immemorial, and even in recurrent pregnancy loss, as well as preterm labor also,
Yes,
and we
yes.
have found very good results in those days. So I think, this continues, and the presentation also improves, isn't it? Because of the nitric oxide production. So naturally, I think, the continuation of pregnancy is also good. That and
by proper complete remodeling of the spiral vessels, it is able to prevent preeclampsia. That is also one newer thing that we have to.
That with the dydrogesterone now they say. Yes.
So the patients with a gestosis score of more than 3, along with the addition of low dose aspirin of 150 milligram, I think we add up 20 milligram of dydrogesterone, we'll be getting a favorable outcome. So that means all ART conceptions are gestosis score more than 3. So that means we all put routinely low dose aspirin. Addition till 36 weeks of pregnancy, I think it can take the pregnancy to term, as well as prevent preeclampsia, as well as prevent IUGR.
There was a question, Dr. Ramani, about the low molecular weight heparin. Dr. Tripurasundari was asking, do you also add that in recurrent pregnancy loss? If it is not APLA or if it is APLA?
See, madam, in the guidelines, all the guidelines are telling, that is whatever guidelines I have shown, ESHRE, ASRM, Swiss guideline, Austrian guideline, German guidelines, everybody is in favor of using low molecular weight heparin if we know that the patient is APLA positive. Otherwise, we do not, there is no need, but still in the presence of clinical evidence of 2 or more pregnancy losses, and we do not do the antibody estimation of so many other antiphospholipid antibodies. Like we are doing only anticardiolipin and antibody, and probably antibody to beta-2 specific glycoprotein. It is a cofactor. But in the event of other lipid, antiphospholipid, other antibodies, maybe there is a role in using low molecular heparin for prevention of recurrent pregnancy loss. I do use it, but the evidences for the use of intravenous IVIG, GCF, and all paternal third-party leukocyte, all those things, according to the recent guidelines in 2022 that was published last month in April, says there is definitely no role for all these things. So this one I wanted to think, maybe if I use a low molecular heparin, I use it till 16 weeks. Beyond that, I continue only progestin and low molecular weight heparin.
Thank you.
Maybe we can do we can assay the when we do the 13th week NT scan, we can again do the placental factors, all those things. Maybe if it is becoming, if the level of
progesterone
low down, maybe we can continue to use that.
Good evening, Dr. Ramani. This is Dr. Tejavati from Bangalore.
Good evening, Teja. Nice to see you.
I know. No, I just wanted to share. I'm not an infertility specialist, nor do I treat SEN, but been in obstetric practice for the last 32 years. So I would, like to answer your second question. In my years of practice, I have found the complaints much better in patients when they are on dydrogesterone. They do not complain, because progesterone, I've had patients coming with giddiness, tiredness, and a lot of other complaints.
Sleepiness also.
Yes.
Drowsiness. Progesterone induce sleepiness. Then one more thing is, yesterday I had a new experience. One patient came and told me, after she was prescribed vaginal progestin, she started having severe itching and itching below the hip. So then it struck me. I asked her whether she is allergic to peanuts. She said yes, she was allergic to peanuts. Probably that is the peanut oil which we are using as a base for the vaginal progestin has provoked these changes. So that particular patient, I have just simply converted her to dydrogesterone. Now she is fine.
So that is what one is compliance. There is no question of doubt at all when you compare. So you are a little happy when you put them on dydrogesterone and they're, continuing pregnancy. Whereas progesterone, so many times I had to stop, in between. So that patient is, not troubling me, calling me up and coming to the clinic on and off. So that's one thing. Secondly, I just wanted to, even in recurrent pregnancy loss, as you said, I think using dydrogesterone right from, if a patient has come to you, even before conceiving, say if you're taking, luteal phase, you just start and then you continue. I usually continue till about, say, 14 weeks. I don't give them till 20, especially in RPL, recurrent pregnancy loss. I think
one thing is, patients with recurrent pregnancy loss or any antenatal event of threatened abortion are likely to go for preterm labor. So that is one high risk.
With that thought, I think you can continue.
Yes. Madam Balama, madam, what is your experience, madam?
Yeah, any bleeding in the first trimester also lands up with, even if it gets controlled, it lands up with a preterm labor.
Yes.
That is the incidence of preterm labor is very high in early pregnancy patients.
Yes.
So that is also another thing, and that is prevented by dydrogesterone. That also.
Manish, you wanted to say something?
Yeah. Yes, madam. Thanks for putting the FOXI guideline 2015. I am part of that making FOXI guidelines. So today we are doing IPL. Everywhere there is IPL. So asking the answer of madam questions, why not 16 week? It is 20 till 20. 20 milligram of dydrogesterone says 20 week of gestation. So in IPL 2020, use 20 milligram of dydrogesterone till 20 week of gestation in recurrent pregnancy loss. And this is not me saying, this is Professor Howard Karp has also mentioned in his book, and in FOXI position statement of usage of progesterone, we had specifically mentioned that up to 20 week of gestation, you have to prevent that pregnancy for going recurrent pregnancy.
Preterm labor,
So 20 will 20.
I would like to add 1 or 2 points. One is the first trimester bleeding, when we start the progesterone, when we feel that it is a threatened abortion kind, all of us do give that loading dose of dydrogesterone. That is 40 milligram dose of dydrogesterone, and that has helped many of my patients. Like 4 tablets, take it right now. That has continued many of our pregnancy who really have this very similar complaints of pain in the lower abdomen, little bleeding and all that. And second thing is, many of the cases where they had previous cervical stitch, diagnosed case of cervical incompetence, also many of the times we have averted by using the dydrogesterone.
Madam, one of the cause of threatened abortion, Professor Howard Karp has mentioned in his book that there is a evidence says that there is a low progesterone causing threatened abortion. If we load with 40 milligram of dydrogesterone and 20 milligram of dydrogesterone, still bleeding stops. If you want to use vaginal, you have to use 400 milligram BD, that is 800 milligram is the dose for vaginal progesterone. And madam has rightly mentioned that when she is bleeding, if you allow her to put something in vagina, they don't allow it.
Nobody likes
it. And in India, abroad, everywhere, everybody is pushing suppositories. Even if you in India, you want to put some suppositories, they won't allow.
Yes.
So in India, the acceptance of dydrogesterone, as madam has rightly mentioned, is very good. And in insufficient dose of progesterone is one of the cause of threatened miscarriage. So if you give progesterone 40 milligram, 20 milligram BD, still bleeding stops, fantastic result you will get.
Yes, agree.
So that evidence has said that the time taken for the stopping of bleeding is very short with dydrogesterone when compared to vaginal progesterone. So
can we go on
to the
next talk? I'm sorry, I actually, my power went off and that's why I was cut off for some time. But I logged in from my iPad then. So we will talk about medical management of preterm labor now. It's a continuum of the threatened miscarriage, as a matter of fact.
Okay. So the background is globally 15 million preterm births are reported every year. Whatever achievement we have done, we are not able to bring down the incidence of preterm birth. That is the truth. Early preterm birth, why we are so much bothered? Because it increases the morbidity, mortality due to immaturity of the fetus, resulting in RDS, cerebral palsy, etc. Again, the multiple gestation pregnancies are associated with increased risk of preterm labor. So now we know currently because of ART and other fertility treatment, the incidence of multiple births and higher order of births are all increasing. So they are in way causing indirectly adding the incidence of preterm birth. So ACOG recommends prophylactic progesterone supplementation in women with a history of preterm birth and women with a short cervical length to prevent preterm birth. So the incidence is 25% in third world countries, 5 to 10% of the developed countries, which remains the same. 13 to 15 million babies are born every year preterm. And again, India ranks the #1 in world preterm birth. So we Indian obstetricians, we have to focus upon this topic very much. Again, India ranks second in preterm specific neonatal death rate. So we are the one who can prevent both the incidence as well as the morbidity and mortality of the newborns. So the short-term morbidity for the newborn is the baby is born with periventricular leukomalacia, intraventricular hemorrhage, PDA, necrotizing enterocolitis, and infection. Long-term morbidities are so huge: neurodevelopmental handicaps, cerebral palsy, seizures, blindness, deafness, bronchopulmonary dysplasia, and retinopathy of prematurity. So Dr. Professor Arul Kumaran was mentioning in the recent AICOG where I chaired a session, he was telling the incidence of HIV babies are much more in India when compared to the Western counterpart. So again, prematurity is going to be one of the important causes. I think everybody is aware of the mechanism of action of preterm labor. This is progesterone is the main key factor because progesterone maintains the uterine quiescence by acting at 4 sites. It at the placenta, level of placenta, it regulates the timing of labor via controlling the stress hormone, that is CRH. In amniotic fluid, it limits the prostaglandin production. At the fetal membrane, it blocks the pro-inflammatory cytokines induced apoptosis, preventing premature PPROM. Then at the myometrium and the cervix, it suppresses the inflammatory response and myometrial contractility. So the screening is bacterial vaginosis and UTI. Again, vaginal microbiomes and the uterine microbiomes, they play a major role in preterm labor, where we always try to increase the healthy lactobacillus group in the vaginal flora. That will help in the prevention of preterm labor because it can promote the anti-inflammatory factors can be promoted. Again, UTI, all of us know it is one of the important causes. Then assessment of cervical length. Start from the first trimester at the NT scan itself. Then fetal fibronectin, we don't do it, only for research purpose. These are the risk factors for preterm labor. That is the maternal risk factor is ethnicity, low or high BMI, smoking, maternal periodontal disease is again gaining an importance factor for preterm labor, uterine anomalies, prior cervical procedures, extremes of age, lower socioeconomic status, educational status, stress, and depression. So again, the other from the reproductive history, some risk factors. One is preterm labor. I think that is the foremost. You give the maximum points to that. Second one is prior stillbirth or pregnancy loss greater than 16 weeks of gestation, induced abortion or curettage, and cervical insufficiency. So other risk factors are again the first trimester bleed, vaginal bleed, shorter or longer intervals of pregnancy. This is the current pregnancy characteristics. Then the next one is use of ART itself can increase the risk of preterm birth, multiple pregnancy, polyhydramnios, short cervical length. So these are some of the risk factors. So all the same thing is given here in this chart, but they have classified what are the things that can be modifiable, non-modifiable, and major thing. So the major risk factors are, one thing is short cervix, less than 25 millimeter prior to 28 weeks of gestation. Again, you look at history of preterm labor, and then it can recur in the 35 to 50% of the pregnancy. So this is the most important. Previous history of preterm delivery is the most important risk factor, followed by the short cervix. Then modifiable risk factors are, of course, the bacterial vaginosis can be treated, recreational use of drugs, tobacco use, correction of UTI, genital tract infection, low pre-pregnancy BMI. So here comes the role for pre-pregnancy counseling also. Again, we need to correct the medical disorders such as thyroid disease, diabetes, hypertension. All those have to be controlled prior to the woman planning for pregnancy. Avoid excessive physical work. Periodontal disease has to be corrected. Sexually transmitted infections has to be treated properly. Short pregnancy interval. So the non-modifiable factors are again the black race, history of abdominal surgery or cervical conization, multiple gestation, uterine anomalies, vaginal bleeding caused by placental abruption or placenta previa. So how do you identify? The traditional method of asking for the history and then cervical length measurement. I think first we do the cervical measurement length at the NT scan level, then again at 20 to 24 weeks, and it can definitely help in the prediction of early spontaneous birth in singleton or in twin pregnancies. And again, routine screening, the guideline, what the guideline says. Is it needed in all the pregnancies? Now, FIGO and European Association of Perinatal Medicine says both of them are in favor of doing an universal screening of pregnant women by mid-trimester. If you fail to do it in the first trimester, or if there is a prior history of mid-trimester loss, never fail to do a cervical length assessment when you are doing an NT scan. After completion of NT scan and the double test or whatever the marker you are routinely doing, we have to think about planning for progestin or planning for cervical encerclage. And now in that we are having the Arabin pessary is also there. Arabin pessary, in my personal use, I think it is a very good one, non-invasive or procedure for cervical incompetence. So then coming again to the inflammatory and the immunological factor that causes preterm labor, upper genital tract infection, where any infection there is pro-inflammatory cytokines are increased. Higher levels of inflammatory cytokines in uterine tissue, cervical vaginal fluid, and placenta of women with preterm labor have been identified, and association of Th1 dominance is seen in preterm labor. So this is again how the progesterone is capable of modulating it. It can progesterone, either a natural progesterone or a dydrogesterone, either by a direct action or by indirect action. It can suppress the anti-inflammatory cytokines, can be increased, pro-inflammatory factors can be reduced, and again by indirectly it can promote the progesterone-induced blocking factor, promoting the anti-inflammatory cytokines, which will ultimately lead to the success of the pregnancy. So the progesterone-induced blocking factor is actually a lymphocyte-derived protein. It's very, very important mediator in progesterone-dependent immunomodulation. The level fails to increase during pregnancy in patients with diagnosis of threatened preterm delivery, and it plays a main role in maintenance of the pregnancy. So what does it actually, progesterone-induced blocking factor, do? It inhibits the synthesis of prostaglandin by inhibiting the arachidonic acid release. And again, prostaglandin is the one that is essential for the contractility of the uterine smooth muscle. So by inhibiting this can prevent preterm labor. So in short cervix, what is the role of progestin? What the clinical evidence says? There is a strong evidence to support the use of progestin in prevention of preterm labor with a short cervical length. Suppose if you come across a short cervical length in your first trimester scan or between 20 to 24 weeks, then we have to have an eye over this patient, and because they have a higher chance of delivering preterm, and this patient, we know all the complications of the preterm labor, RDS, etc., and then neonatal admission and neonatal morbidity and mortality. So such patient, if she is going to be a primigravida with a short cervix, what the evidence says is just put the patient on progestin. That is more than enough. But if there are more than 2 or 3 pregnancy losses in the mid-trimester, then the evidence says that you can go for a cervical, you treat the patient as cervical incompetence, and then you can go for encerclage. But remember one thing, in multiple pregnancy, there is no, in the event of short cervix, there is no role for encerclage. or even progesterone helps only to a certain extent. It will take its own course because the expected number of pregnancy period is only 36 weeks for a twin pregnancy, and it is getting reduced to 34 when it is going to be a triplet. So progesterone in preterm labor and premature rupture of membranes. What the fact says is, it prevents shortening of the cervix, it inhibits the inflammation. So in short cervix, when we are using it, it prevents the further shortening of the cervix. Then again, it can be used as a maintenance therapy after you initiate acute tocolysis. Suppose if your patient comes to you with 28 weeks of pregnancy or between 24 to 28 weeks of pregnancy with the onset of uterine contraction suggestive of preterm labor, then we always tend to use an acute tocolysis. Tocolytics are used, but combined with progestin, because tocolysis we cannot continue for a longer time, either a magnesium sulfate or you can use nifedipine, but you cannot continue for a longer time. But it can be taken over by progestin, which can help to promote the, it can prevent the preterm labor. So what the progesterone does is increases the gestational age at delivery, increases the neonatal birth weight, and decreases the low birth weight babies. And the maintenance therapy by oral micronized progestin has been given as 200 milligram daily. It has to be given continuously. Now, what is the timing and duration of the progesterone supplement therapy? Whenever there is a history of preterm labor, better to start the patient with progesterone between 16 to 24 weeks or as early as possible when the patient comes to you. Then when you see and observe a short cervical length, that is mainly in a primary gravida, start the patient on progestin, and the duration of the therapy is you have to continue till 34 to 36 weeks of gestation, or when the patient comes with a rupture of membranes, or to say that the patient, the fetus is made completely viable. Again, the dydrogesterone use. What is the role of dydrogesterone in preterm labor? So far, we have been talking so many things. All the trials are in favor of micronized vaginal progestin or the micronized progestin for prevention of preterm labor. But of late, we know that dydrogesterone is gaining more popularity in significantly reducing not only the miscarriage rate, it also demonstrates the ability to reduce the development of preeclampsia, about which we have discussed earlier, because it increases the production of interleukin-10, progesterone-induced blocking factor, which are favorable one, and suppresses the interferon gamma. So it can be considered for use until late pregnancy to prevent preterm labor. Now, what are the evidences for use of dydrogesterone? It was in Hudick et al. Study where he says that preterm labor dydrogesterone treatment is effective even when preterm labor has already set in with the intact membrane. Higher doses, maybe start with a dose of 40 milligram in women with a risk of preterm labor and taper it to 20 milligram. Increase PIB of interleukin-10 while reduction of interferon occurs when you start with this dose. Again, Schinder's study, dydrogesterone at a lower dose could be effective in prevention and treatment of preterm labor. So when you want to do it as a prophylactic, maybe 10 to 20 milligram dosage may be sufficient. But when the onset of preterm labor has started, you have to go ahead with the 40 milligram. So again, this was a study by Tang Chen and others, where they had compared the dydrogesterone with the placebo group. When they compared the gestational age, there was no significant difference at which the patient delivered. But the time taken for the recurrence of the contraction, but that is recurrence of preterm labor to occur, that was very much prolonged in the dydrogesterone group. So that means it can suppress once. When you stop tocolysis, continue with dydrogesterone, it will definitely prevent the recurrence of preterm labor in contrast to the placebo. So again, this was a study where they have compared the dydrogesterone versus progesterone in preterm labor. They have found out the incidence of preterm birth was much lower than that of the micronized progesterone, as well as the chances of postpartum hemorrhage was much lower when compared to micronized progesterone. So what is the recommendation? So the patients with a history of previous preterm birth or short cervix 2 into 20 milligram orally, that is almost 40 milligram to achieve preterm labor prevention when used from 16 weeks until 74 weeks, or in patients with preterm labor without rupture of membranes, again 2 into 20 milligram with or without tocolytic agents. That I have clearly mentioned. Tocolytics cannot be given for a very long time. We have to switch over to the progesterone. To summarize, in patients with a history of preterm birth, they rank the highest risk factor for recurrence of preterm labor and short cervix. They are the major risk factors. Again, inflammation and immunological factors like cytokines have been implicated in the pathogenesis of preterm labor. Prophylactic progestin supplement is recommended in women with a history of preterm birth and women with short cervix. And progesterone supplement has been found to be effective in preventing preterm birth. Dydrogesterone shows rapid and direct inhibition of the myometrial. It acts both directly as well as indirectly, and dydrogesterone can be considered for use until late pregnancy to prevent preterm labor. So now the questions for panel discussion are whether you can use inflammatory marker like CRP for predicting preterm labor. Panelists, you can go ahead.
Madam, one thing I want to tell regarding the preterm labor, that you cannot predict preterm labor.
Yes.
You cannot
That
predict
is 100% true.
So first we have to ask question to a lady, just like in Bible, thou your neighbor, give thou your ears. Listen them carefully. If they have got previous history of preterm labor, one previous history of preterm labor, two previous losses before 20 weeks of gestation, he had done TVS, that is transvaginal ultrasound, means if there is T, V or U, that is means funneling. So if there is in the T, V, U, you have to consider short cervix and you have to go for osteotomy. So we can only prevent, we cannot predict. No inflammatory marker can give you that this lady can go for preterm labor. Professor Nicodemus has started a trial with progesterone use in prevention of preterm labor, 400 milligram vaginally, then 200 milligram for comparable dose. On the same note, Professor Raj Raghupati and Al-Zebi, you had mentioned all the paper of Professor Raj Raghupati and Al-Zebi that is published in 2022. Yes. That we had discussed that if micronized progesterone is preventing the preterm, then why not the dydrogesterone?
Yes.
Let's make a paper on it. So they had done study and they had proven that this PIBF, interleukins, TH1 to TH2 cytokines, uterine prisoners, everything is where there with dydrogesterone. In between these two, micronized and dydrogesterone, you have got one era of hydroxyprogesterone caprice, weekly injections to prevent the preterm labor. So now we have got three things in our armamentarium. You can use vaginal progesterone, you can use hydroxyprogesterone caprice weekly, or you can use dydrogesterone. But dydrogesterone has got beneficial effect of uterine queasiness, increase in nitric oxide, increase in the PIBF, increase in the TH1 to TH2 cytokines, increase in the duration of delivery, duration of contraction to came previous preterm. So there are distinct advantage of using dydrogesterone in preterm labor. So it is a fantastic, madam, and congratulations for wonderful presentation.
Sir, I would like to share some of the papers. Anybody has got a controversial opinion whether inflammatory biomarkers like CRP are useful? Do you think it is quite useful?
No, I don't think it is useful at all. I don't think it is useful at all.
Yes, madam. I was also thinking till I saw this paper that was published in 2020, elevated C-reactive protein and complement C3 levels are associated with preterm labor. So this was a study that was published in open access. This one there, the conclusion is elevated CRP and C3 in first trimester was associated with the increased risk of preterm birth. Inflammatory indicators may play a pivotal role. I do not know how much to use in a clinical practice. Maybe we need to have more studies should come out to say that CRP levels are actually useful. So,
Madam, I would like to add here.
Yes, JP, welcome, most welcome.
Madam,
go ahead.
Thank you, madam. And like doing these CRP levels, we are doing quite routinely, madam, especially for those individuals who are having preterm labor and those who had any treatment for infertility, long-term infertility, and those who came with ART, all of them we are doing the CRP, madam. And we have found that the levels of CRP very high, correlating very well with the incidence of preterm labor, madam. So
then you should publish this paper, Jayanti.
And also, madam, we have found such a close correlation between all these things. We are not putting any cerclage also without doing a CRP level. And that is a nice cheap method in our country. We can easily use it, madam. It is very useful, madam.
Yeah, we will try it and see, Jayanti. Yeah.
Yes, madam.
What you say is true.
I just wanted to know, is it, non-specific thing? I was thinking CRP, madam.
Yeah, even I was thinking as non-specific.
Yeah.
So until I came across this paper, so maybe
Madam,
But in that paper, ma'am, there might
actually,
be some
how I
associated co-factors, no? Risk
Yeah.
factors. Were they ruled out?
Yeah.
The
Madam, when
associated
we were,
risk factors, were they ruled out, the
Adjusted
history of
factors.
PPD and all that factors?
long back when I was actually giving one talk on this dydrogesterone only, and we're talking about immunomodulation, that innate immunity and the cell-mediated immunity, and in that they were telling about the correlation between this very long back, madam. The early papers were saying that there is a, how would you know that is by looking at the CRP. So I got that idea from there, and from that time I started using this CRP levels.
this was quite a large number of study from 6,200 patients. I think we need to, that was done between 507 and 3467 weeks of gestational age. And I think the 206 women, they have delivered preterm. So we should get into the details of this.
Maybe we need more studies, madam.
Maternal age, birthplace, gender, and the gender wise, as they have suggested in few of the papers, that male babies, they always tend to have a preterm higher. Preterm incidence is higher. Okay.
Maybe
so
we
then
Was it a retrospective study or a prospective study?
It
Because
was
I think there might be a lot of confounding factors.
Yes, that way.
Yes,
that was
yeah,
it.
exactly.
It was, I think it was only a prospective study because they have enrolled and between 2015 and 2016. I'll get into the details anyway.
Maybe a few more larger studies, no? Many will add on, some.
Jayanti, when did you do the CRP? At what period of gestation?
We are doing initially also and around 20 weeks, ma'am.
No, initially also means as soon as pregnancy test is positive.
Yes. When we are doing all this, when
For
they
everyone,
come
for everyone.
around like that, yes.
For everyone.
We are doing it.
And you
everyone you are doing, or with the history of preterm
No,
Risk factors.
I have given all that risk factors for those people only.
Okay.
It's not a routine investigation.
No, I'm not doing for all the patients, all the mothers.
Yeah, with the women with the risk factors for preterm birth, we can probably, it can be, if we do it in a multicentric trial, it will be of use.
Yes.
Okay. So then coming to the next question, your clinical practice, what is the dose and timing and initiation of progesterone supplement in patients with the risk of preterm labor?
Usually, madam, I start around 16 weeks and continue till 34.
34. I think most of us do the same thing.
Yes.
16 to 34 weeks. But I give the option of either a micronized progesterone or even hydroxycaprivate. I use quite liberally because some of the patients, they want to take the shots once in a week, or dydrogesterone maybe. What is the most appropriate dose and time of dydrogesterone? I think
16 weeks.
16 weeks, 20 milligram.
Yes.
Dose per day. Then how should
Yeah.
the patients at risk of preterm labor to be counseled? So how will you counsel the patients who are at a risk of preterm labor?
No, we can only tell them that we can try and prevent it, but we cannot tell them 100% we are going to prevent. And we have to tell them that they have to deliver in a center where there are NICU facilities, so that even if they deliver early, the baby can be taken care of. So all this we talk, and even when we are doing an encerclage also, we tell them the same thing. The encerclage may not prevent a preterm labor. And in fact, if she sets into labor, the stitch has to be removed immediately. Otherwise, it can cause tears in the cervix, which will become a worse problem in the next pregnancy, So all this counseling is very, very important.
Yes.
So this was again a paper which I found out a review article in 2017 published published in 2017, where they have given certain criteria for counseling. So that is providing written information, exploring parents' pre-existing preferences, beliefs, and values, and more research and is more needed. So all these things, I think we have to individualize and we have to sit and discuss with these patients. I think
Dr. Ramani, I was just, enlightened with the new studies which you have just told regarding this progesterone in preterm. You said recently, March 2022. I think from now on we should start using, since compliance is good. So I think we should start using dydrogesterone in preterm labor with the latest evidence, whatever you have given us, I think.
Especially now that we have only Nicardia, which we think prevents preterm labor. We do not know how long to use it. We can give it only for a short period. We do not know whether we can give it for a longer period. So dydrogesterone is a big blessing if we can prolong it.
Yes.
We can ask them to take it for a longer time safely. So we are also safe.
We are worried about the side effects, adverse effects. So
You just
not
can't
there. It's a big boon to.
That's what.
We don't want
tell the patient,
That's why, madam, it is a dydroboon. That's why it is a dydroboon. That's why it is a big boon.
We don't want the vaginal progesterone because of irritation or bleeding, they're not compliant, etc. We don't want intramuscular injections. We don't use, as Madam Chitra said, nifedipine for its own side effect. So ultimately, we are left most compliant with progesterone. And to Dr. Jayanti, I had a question. You do CRP in the beginning, you said, and again you repeat later on. What is the inference you get on your repeat? In the sense, do you check for a manifold increase in the CRP? How do you judge your values, and how do you decide the dose of your tocolytic?
So when we are doing initial, that is only for those individuals we have what maximum around 16 to 18 weeks we are doing the CRP levels, and that's when we can start giving our tocolytic agents, and then when it is very high, we are also giving one course of antibiotics, but that is something which is we are giving as a prophylactic, because we know sometimes it may be useful also, because we know some of the preterm labors are because of some infections which are there.
No, the streptococcus, it can also cause,
And how many cultures
we do give antibiotics,
never comes positive. So that is why we give in these individuals. Yes. And of late, madam, 2 cases which were having this sort of thing and was not responding to any of our tocolytic. We have given dydrogesterone, madam, for 2 patients, and they went nicely to term. So I'm also beginning off late to start using dydrogesterone for preterm labors.
No, we've been using since a long time dydrogesterone.
But I was not using, madam.
Without any of these evidences also we were using before all these papers came up, we were using this in threatened abortion as well as in preterm labor. And now that we have evidence, all the more we should use it.
To practice, I think evidence is very important. So
yes, nowadays evidence-based medicine is very important. Those days it wasn't. It wasn't important.
Madam, of late, microbiomes are gaining more and more importance in preterm labor.
Yeah.
So that is probiotics. See, Dr. Gaura has posted.
We are using probiotics also, madam.
Probiotics. You should expect the level of lactobacillus to be more than 90% in the vaginal microbiome. That is a favorable one.
Dr. Ramani, I spoke on this probiotic.
Yeah, my paper has been published recently on microbiome in reproduction. We have published on paper.
Yeah. If it is probiotics in the endometrial cavity also, that matters when there is a vaginal probiotic increased population.
See, that too, recurrent abortion, in recurrent miscarriages or recurrent implantation failure. Now, one study called PREMA study has come out where they do the microbial analysis, that is unhealthy bacterium. Some 18 bacteria, including bubunculus and so many other organisms, including this Mycobacterium tuberculosis, are being done. along with the estimation of the lactobacillus. So they give us the proper what sort of antibiotics we should use, and then repeat it after a course of antibiotics for a period of 1 month. Repeat it. So unless one of my patients, when she was waiting for an embryo transfer, she conceived spontaneously with the correction of the simple microbiome.
But is it available? This analysis is available?
Yes, very well available. Very well. They are doing it in Chennai. I think in Bangalore also there is Viva Genix. That is one laboratory.
The cost, Dr. Ramani? What about the cost?
The cost is around 13,000. But for if you do it primarily, they give the result, then repeat it after 28 days. They don't charge it. So n number of times, even if you repeat it till the it becomes negative. It becomes it is totally the.
Some cases it's worth. In some cases it's worth doing.
Yes,
test.
yes.
And when we use the probiotics,
are costlier than treatment. So for every patient, we will not be able to do all the tests. I think giving empirically some treatment for patients is better than going for all high, because IVF center, they can afford to get all the investigators. Xenogenical is not possible.
Madam, for that you can just put them on a course of doxycycline, metrogel, and failure of which even clindamycin can be added. But you continue to supplement with probiotics for quite a longer time.
Correct. This is what I also do. I put them on metrogel and doxycycline. Continue the probiotics. That is
yes, madam. Yes.
I think probiotics are gaining momentum now.
More important.
Not only here, in all the other aspects of maternal health.
It is only the gut probiotic that is available, and vaginal probiotic is not available in India, according to my knowledge. One thing, and second thing is the probiotics.
Vaginal, no, Rekha. With these new vaginal washes coming, everybody is washing their vaginas with all sorts of things. I think, that is why the probiotics are very, very important in these women.
Yeah, probably in those washes, the probiotics should be added.
Yes, but if you correct the gut biotic, it will automatically correct.
Yes, very important. Gut biotic.
Abroad, the vaginal suppositories are also available. Vaginal probiotic suppositories are available. And second thing, these probiotics have to be except for some companies, most of them, we have to instruct the patient that it has to be maintained in the refrigerator between 2 to 8 degrees. Otherwise, it doesn't work.
See, another thing is now the concept of diseases itself is based on microbial pattern of the gut. Like the PCO has got a fixed pattern of microbial alteration, endometriosis has got a fixed.
In fact, in vaginal deliveries, the microbiome of the baby is also supposed to be
seeding
much better than cesarean,
because it is aspirating. So that is also
seeding. They purposely do the seeding of the vaginal tissue of the mother to the fetus. So everything a day will come when we can manipulate the entire disease with the antimicrobials, manipulating the microbiome.
Yeah.
Yes. Madam is all the circle around.
Yes.
If you see in previous era, they used to do douche with this curd water.
Curd wash.
Yes.
Curd wash. That is all lactobacillus.
What curd wash where, Dr. Manish?
Yeah, it was mentioned in all literature that curd has got lactobacillus.
Yeah, curd wash where? Vaginal.
No, in the vaginal previously, when there is nothing was available. In the ancient era,
conventional treatment.
Most of the South Indians.
So now it's coming back. Now it is refined, more refined.
Back to square one.
Most of the South Indians end up their food with curd rice, isn't it?
Yeah.
So that itself also is improving the gut biotic, gut probiotics, I think. Yeah, gut microbiome. I think we have had a very
and curd has got very good whey protein, so it is also very good to prevent OHSS.
Tryptophan also it has got.
Thank you. It was a very nice discussion on dydrogesterone as well as the progesterone.
Yes.
Yeah,
because we are crossing our time limit.
Discussion. I think I must thank Mankind for giving us this time and a very useful discussion.
Very informative.
Dr. Manish and Dr. Ramani. Good discussion. Thank you.
Somebody is asking about IVIG. The current literature April, it was
2022.
which shows that there is no role for IVIG in recurrent pregnancy loss as a immunotherapy.
Correct. Thank you, Dr. Manish.
Thank you.
Dr. Ashutosh.
Thank you. Yeah, ma'am. So with the permission of chairpersons and moderators, I would like to place vote of thanks. Thank you very much for all the advisors, our chairperson, moderators for such an enlightening session. This has definitely helped us a lot, and we understand that you have taken time out of your busy schedule, and your suggestions and opinions shared on this platform matter a lot to us. We are hopeful for your continued patronage and guidance in the future. I would just request Ramesh sir to place vote of thanks to all the advisors who have joined online with us in that advisory board meeting. Over to Ramesh sir.
Dr. Ajat and Dr. Ashutosh, sorry for shifting from dydrogeterone. It's such a nice platform to curds. As
No,
Dr.
no,
No issues, ma'am. No issues.
Put with curds. Now our webinar we ended with curds. Sorry.
So, respected doctors, thank you very much for your valuable participation today. And a lot of take-home points are there. So, very well interacted way. All South India experts are participated in this meeting, madam. I thank you very much for chairperson.
Thank you so much.
Thank you, sir.
Thanks, everybody.
Thank you. Good night. Balama madam, thank you so much for your moderation.
Thank you.
Thank you, madam. Thank you.
Thank you.
Thank you, ma'am.
Madam, Balamba, madam, area power is off, madam, actually. Madam is participated, madam, actually.
Thank you.
Thank you so much.
Thank you.
Thank you,
Thank you,
Bala.
everyone.
Good night. Namaskar.
Good night.
Namaskar, sir.
Thank you.
Entire mankind team. Thank you so much.
Thank you, sir. Thank you.
Thank you.